So last time we were talking about the factors that affect the breathing, and those simply are three that you need to remember: oxygen, carbon dioxide, and pH. And we said that the carbon dioxide, all the three are actually linked to breathing, but carbon dioxide and pH are specifically linked to each other. Carbon dioxide in the blood goes up, hydrogen goes up, pH goes down. At that same time, oxygen will go down anyway. So remember these three factors that are helping to regulate and affect our breathing: oxygen, carbon dioxide, and pH. And remember that the central ones are affected with the pH, while the peripheral ones are affected more by the carbon dioxide and the oxygen. Now, some clinical applications, including what happened when you exercise. If you think about it, if I am exercising, there are two things happening at the same time. When I exercise, it means I'm breathing faster, so I'm getting rid of carbon dioxide and getting oxygen back. But it's not like that, because you're not. This is different than hyperventilation. Exercise is completely different than hyperventilation, and understand the difference. If I'm sitting down right now and I'm going like for some reason doing this, this is called hyperventilation. If I do that, I'm going to get rid of carbon dioxide. So carbon dioxide inside my blood will drop, leading to alkalosis, and the oxygen will go up. This is if I am just hyperventilating. But if I'm exercising, it's a completely different story, because if I'm exercising, even though I am hyperventilating, but at the same time, I'm utilizing the extra oxygen that I'm getting in, and I'm adding more carbon dioxide because I'm working actually. So my muscles and my body is going to use whatever the oxygen that you get in, and it's going to add carbon dioxide that you're getting rid of. So the bottom line is, it's not going to change with exercise. So the oxygen and carbon dioxide and pH doesn't change with exercise. No, it doesn't change much. It changes a little bit. But what doesn't change? You think about it, but I'm breathing more. Yeah, but you have two things that are balancing to each other. Even though you're hyperventilating, but your body is doing the opposite. Hyperventilation, you're getting rid of carbon dioxide and getting oxygen, but your body is exercising, so your body loading the blood with carbon dioxide that you're losing out, and it's taking the extra oxygen, so that the net result is nothing much. Minimal change, or not significant change. And what's happening here is that your cerebral cortex, I mentioned before that the control of the respiratory system is located in the medulla and the pons. You have the pontine and the medullary centers. And the medullary centers are the rhythmic one. These are the ones that set the basic rhythm. The pons is above that. So it's modulating or modifying that. But on the top, all the way on the top here, your cortex, it can have even a higher job. Remember, your cortex is the top. This is the CEO of your body, the cortex. It goes like spinal cord. On top of it is your brainstem. On top of it is your brain. On top of everything is the cortex. The cortex is like the president of your body. So every time we say a control of something, remember that your cortex can overcome that, can play even a higher role. So that explains, if you're just thinking about something, like I'm sitting down, I'm not doing any exercise, I'm not doing anything, but I'm thinking about something that make me like kind of stressed. That can make me hyperventilate. This is the cerebral cortex. So if you're exercising, your cortex is going to send the signal to your respiratory centers, to send the signal to the muscle, to your respiratory system to go faster and compensate for that. So meaning the bottom line is, exercise, even though it stimulates the respiratory system, but it stimulates your cardiovascular system at the same time, and your body's working, so the net result is minimal or non-significant change. Now the alveolar gas exchange. I talked a little bit about that. And this picture is showing you like you put endoscope within the alveolar sac, and you look at these alveoli. The alveoli are microscopic structure. They are very small. They start from the alveolar duct, if you still remember. And I told you before the sequence, whether the sequence that you know it one by one, or you look at the picture and tell me what it is. This is very important, and I'm telling you. Okay, this is in the core of the chapter. You will be asked about it a lot. So you need to know this, starting from here, from your nose, going down to your pharynx, to your larynx, to your trachea, primary bronchi, secondary, and all the way until you get to the alveolar ducts and alveolar sac. Now at the level of the alveolar sac, the alveoli are going to, because they are very thin, they are going to allow gas exchange that I discussed a little bit before, but we're going to expand a little bit about the wall itself and how the process occur, including a couple of numbers. Beside the exchange that's happening across the wall of the alveoli, we also have something called the alveolar macrophages. Alveolar macrophages, remember before when I told you the perfect air is that air that is clean, humid, and moist, or humid, clean, warm, and moist. This is the perfect air, but clean doesn't mean 100% clean. You clean it as much as possible. So as the air goes in, the hair is going to trap some, the mucus secretions are going to trap some, the turbinate are going to trap some, the cilia are going to trap some. But after all of that, the air that goes all the way until the end of the tree, I usually say the alveoli is like an apple itself, the fruit itself. If you look at apple tree and you look at the trunk, branches, until you go all the way, you see an apple that's attached by like a small duct or something like this. It's an attachment. This is exactly, the apple is like the alveolus, one alveolus. And what's connecting it is like the alveolar duct. So if you go all the way to the end of the tree, which is this apple or this alveolus, the air is still not 100% clean. You might still, usually you still have a little bit of a dust or something like that. The macrophages are staying over there, just waiting for anything that escape all of this filtering mechanism and is going to eat it and get rid of it. So we call those the alveolar macrophages. Sometimes they call it the dust cells, but alveolar macrophage is more common. Dust cells, because these are the cells, the macrophages that eat the dust. Now, if we talk about the alveolar membrane itself, the membrane, that tiny thin membrane that allow the exchange of gases across, it consists of two types of cells and a basement membrane in between. The two types of cells, the major one that's making the major structure of the alveolus is simple squamous epithelium. Simple squamous epithelium, we call it type 1 cells. So what's the function of type 1 cells? This is just the main component, the main cells making the alveolus itself, and it is squamous, means squeezed, means flat. In order to allow things to exchange, you have one layer only, single layer of squamous epithelium. This is one side. And then there are other cells that are scattered in between these type 1 cells that are squamous epithelium, and these cells are called type 2 cells. Type 2 cells are not as much as the type 1. It's less like if this is the alveolus, you have one here and one here and one here. It is scattered in between these type 1 squamous epithelium, simple squamous epithelium cells. And type 2 is extremely important because it secretes a chemical secretion, a fluid that's called surfactant or pulmonary surfactant. The pulmonary surfactant is responsible for decreasing the surface tension. It's not mentioned here, but it decreases. I'm mentioning it So know it, it will be good. Decrease the surface tension. It decreases the surface tension. What is the surface tension and what's the importance of that? Here it is. Remember Tuesday, I told you guys that we have two opposing factors or two opposing forces. The force number one is the force of the alveoli itself, especially the alveolar wall, which is the elastic recoil. It makes the elasticity tending to collapse the lung, shrinking the lung. This is one force because of the elastic tissue and because of the surface tension in the alveolar wall. This surface tension is tending to shrink, collapse the lung. Why the lung does not collapse or shrink under normal circumstances? Because there is an external or outer layer, which is the chest wall itself, that is bone and muscles. So it is open. And in between those two layers, we have this pleural space or pleural cavity that contain the fluid, and this fluid act like an adhesion in between those two layers. So the bottom line is chest wall is pulling out and the lung is pulling in, trying to shrink. But because the two layers of the pleura are kind of, it's not really attached, but are adherent, kind of adherent to some extent to each other, this is forcing the lung to open. And that's why if anything enter in that space, the lung is going to collapse. And we will talk about this. But the point I'm trying to make here is, what was the force that's trying to expand the lung, and what's the force that's trying to shrink or collapse the lung? The force that's trying to expand the lung is the chest wall, to which the parietal pleura is attached. And the other force opposing is the elastic recoil and the surface tension that's in the lung itself. And this force is pulling in, trying to collapse, trying to shrink. And those opposing forces, because of the two membranes, one of them is lining the chest wall and the other one is covering the lung, and they come together. So that's what's keeping the lung opened all the time. Unless something wrong happened to separate those two layers, the lung will be free to collapse. Okay? So one of the forces that I just mentioned right now is the elastic recoil, like that recoil of a rubber band. Like if you stretch a rubber band, once you let it go, it's going to recoil, go to the original length. It was stretched because of that force stretching it all the time throughout our entire life. It's all the time stretched. But if at any point you let it go, it's going to recoil. The other one is surface tension, and this is what I'm talking about. We have type 2 cells that are secreting something called pulmonary surfactant, and this surfactant is a chemical compound. It's a fluid that decrease the surface tension so that make it easier for the lung to expand. So some kids and some infants are born without enough surfactant. If that's the case, if you don't have enough surfactant, your surface tension will be higher than it should. So this force of shrinking, collapsing the lung, it's going to become even higher. So that will make the lung collapse. We call that respiratory distress syndrome in newborns. Sometimes they call it the infant respiratory distress syndrome, whatever it is. You need to remember respiratory distress syndrome, newborn respiratory distress syndrome, infant respiratory distress syndrome. It's respiratory distress syndrome anyway. There is another one that I'm going to talk about that's called acute. This is something completely different. I'm talking about the respiratory distress syndrome in infants and newborns. Okay? What's the reason for that? Lack of surfactants. If you don't have enough surfactants, the surface tension increase and the lung is going to collapse depending on how much you have. It's not zero. If it is less, it will collapse a little bit more and it will be harder to breathe. The more it collapses, the more distress that this infant have. And just for your information, this have nothing to do with what I'm talking about right now, but if you're interested to know, if you noticed, if this lady is pregnant and she can give birth and have the baby delivered at 9 months, sometimes they can allow it like as early as 7. Less than 7, the mom is not allowed to take the baby out. Why? Because 7 is when the surfactant, the level of the surfactant good enough that the infant can breathe on his own. But if it is less than 7, he does not have enough surfactant. So they need to stay in the incubators in the hospital where they use like a positive pressure to keep his lung working, and they accelerate the growth and actually the maturation of type 2 cells so that he have enough, and then, okay, you can take the baby now. So this is just for your information. It's related to the surfactant. So now back to the respiratory membrane. I just mentioned the alveolar wall, which is simple squamous epithelium, and this is type 1, and type 2 in between. So what else do we have that the gases need to cross in order to move from the alveolar air into the blood, or the other way around? You need to cross the first one that I just mentioned, which is simple squamous epithelium. And on the other side of which is the blood, we have the blood capillary wall, which is also simple squamous epithelium. So we have 2 layers. And in between, there is something called the basement membrane. Let me show you the picture, and it will make more sense. If you look at this picture here, what you're seeing here, this is the alveolar cavity, which contains the air right here. And this light blue surrounding it, you can see this. This is the alveolar wall, which is squamous epithelium. Now look at this. This is the capillary wall, and you see the red blood cells here. So this is the capillary wall, and it is surrounded. The wall is this pink orange right here. But if you look further, you will see light blue in between right here. And look at this picture right here, like this, the orange or the yellow here. This is the alveolar wall, which is squamous epithelium. And then this one, which is also orange or yellow, whatever you call it, this is the capillary, also squamous epithelium. And look in between, you see this light yellow, and this is a basement membrane. And the gases, in order to do the exchange, they need to cross all 3. But because the squamous epithelium on both sides are very thin, that will allow the gases to easily go in and out, exchange. If this wall for some reason get thicker, it will make that exchange harder. And there are some conditions that we can talk about regarding this. Always remember, if you have a question, stop me anytime you want. Okay, you don't just listen to what I'm saying unless it is making sense and everything is obvious and clear. That's fine. Otherwise, you guys need to let me know. And these are right here, these are the macrophages, or the dust cells, waiting for anything to come all the way to the end, which is this, the alveoli, and they're going to eat it, specifically dust. So this is for the respiratory membrane, and this is the exchange that's going to happen, and we have some details to talk about. Now the diffusion depends on what? Like how much oxygen, like go back to this one right here. How much oxygen is going to cross from the alveolar cavity into the capillary cavity and go to the red blood cells, and how or how much carbon dioxide is going to move from the capillary side into the alveolar cavity. So this is the exchange, depending on what? Factors that are affecting that are, number 1, the surface area, like all these alveoli. If you put these alveoli together, this can make something like a big house. It is a lot, but it's just because it's beside each other, so you don't see it. But if you actually spread it, it's going to be a lot bigger. So we call that the surface area, and this is the area that's available for exchange. Some people will have less alveoli. Some people have the alveoli obstruct or get fibrotic or die or something like this. So those will have less surface tension, which is the surface available for exchange. This is one side. The other side, the other thing is short distance. Like here, you're crossing this. This is like 2 micro or 3 micrometer, which is very thin. If this 3 micrometer become more, like 4 or 5, the distance that you're crossing become bigger. The gas solubility, like generally speaking, both oxygen and carbon dioxide are soluble. They are lipid soluble, so they can easily cross. Anything else is different, but it's not our issue. The other thing is the pressure gradient. I mean the pressure of the oxygen in the alveoli and the pressure of oxygen inside the capillaries. If we say like outside here in the alveoli is 100 and inside is 40, so the gradient is 60, and this is good. If for some reason the oxygen tension or the partial pressure of oxygen or the oxygen tension in the alveoli goes down for some reason, like you are in a closed room or something, at this point, let's say this is becoming 90. So the concentration gradient or the pressure gradient now is 50. Okay, so this is going to make it harder. On the other hand, what if I somehow add more oxygen to the room and it's becoming 110? It will be even faster. So the more gradient, the faster and the better the movement. So this is for the partial gas partial pressure.
Is this why they would put you in a steel lung?
What is that again?
Is this why they would put you in a steel lung?
You put who? Like
if they put a person in a steel lung, is that for the pressure gradient?
A steel lung? I'm not sure about the steel lung. But if you mean if somebody's having, I'm not sure about this point, but if you mean that a person is having a lung collapse and they put them there in order to expand the lung or having more oxygen, it can be. But I can look it up and let you know. I'm not sure about this point. Okay, but generally speaking, these are the factors that help the diffusion across the wall. Most importantly, that can actually change is the surface area, because the surface area can be affected easily. Like if you're smoking or something, you're destroying your alveolar wall. The dust, if you're working in a factory, if you have multiple infections, a lot of these can actually affect the surface area and the thickness of the wall as well. So let's go a little bit into the details. This is the respiratory membrane. And remember, respiratory membrane is not the alveolar membrane. This is different. Alveolar membrane is that squamous epithelium lining the alveoli. This is one. But if you say the membrane, you mean three. One from the alveolar side and one from the capillary side and the basement membrane in between. So now how we are going to cross this membrane. Practically speaking, the average numbers of oxygen, let's say 100. Don't worry about this. Let's say 100 in the alveolar cavity, which is coming from outside, from the atmospheric, and it is 40 inside. So the gradient here, the pressure gradient is 60, 100, and 40. So obviously the oxygen will easily move in from the alveoli to the capillary wall. On the other hand, the carbon dioxide inside is about 45, and in the alveolar cavity, it's about 40. It's not a huge pressure gradient, but the solubility of the carbon dioxide is very high, so it does move. As long as you have a concentration gradient, it's going to move. So what's happening here is oxygen move in from the alveolar cavity into the capillaries, and the carbon dioxide moves out from the capillaries into the alveolar cavity, from the capillary lumen, or from the blood into the capillary cavity. And this is what's happening at this point right here. And then it's going to continue oxygen in, carbon dioxide out, oxygen in, carbon dioxide out, until you go to the other side where it's reverse. Where at this point here, you will see that the oxygen, just to make it easier, let's say 100, and the carbon dioxide is 40, which is what was outside. It is going to be equal to the outside, because all this pressure gradient is going to be changing as you go until the inside it change oxygen, it changed from 40, it become 100, and the carbon dioxide changed from 45, it become 40. So at this point, this is good. 100 for the oxygen, 40 for the carbon dioxide. This is good, and this is what's going to go to the pulmonary veins and will go to the left side of the heart, which is go to the left atrium, left ventricle, and go to the rest of the body. And this is the good blood returning back. So this is it's not exactly, but I usually call it the bad blood is coming, which contain a lot of carbon dioxide and low oxygen, and you exchange until you get to the other side, and this is the good blood that contain a good amount of oxygen and good amount of carbon dioxide. By the way, less carbon dioxide is not good. Just think about it. You think that oxygen is good and carbon dioxide is bad. This is not accurate, because you have to have both of them within the normal range. If like if you say is of 40 better or 35, 35 is better, carbon dioxide is bad. No, that's not true. 40 is better than 35. How about 45 or 40? 40. So the bottom line is normal number. It has to be 40, because both of them, if you go up or down, you're going to change to alkalinity and acidity, and this is not good for the body. The other clinical application, I'm not going to spend much time in this. What happens if you go to high altitude, like you go to high mountain? Most of the time you will have an issue. Yeah, you can have a little bit of difficulty breathing, a little bit. When you go at least if this is your first time, if you're not staying there for a long time, the first couple of days you will say, I'm not breathing well, I'm not comfortable breathing. And sometimes it can be you're not breathing good, to the extent they call it the altitude sickness. You feel like you're sick. What's happening here is, just to make it simple, even though the oxygen is about 21% at the level, at the sea level, and even if you go up to the mountain, it's the same thing, but the atmospheric pressure drops when you go up. So the force that was moving the air into your lung decrease. Less oxygen go in, less carbon dioxide move, and you feel uncomfortable. But the body is going to compensate for that. After that, your body will say, okay, our oxygen is going down, our carbon dioxide is going up. We need to accelerate respiration and the heart rate in order to compensate for that. Sometimes it go to the extreme, which we call it the high altitude pulmonary edema, where because of the low oxygen, the pulmonary vessels can actually constrict. Okay, if that's the case, because this is something unique to the lung. When the lung feel that there is less oxygen coming, it constricts so that the oxygen go to the other side that are working good. But anyway, what happened here is if you constrict, it's going to lead to the part of the plasma leaks out, and we call that high altitude edema. The bottom line that I want you to know here is when you go up, the atmospheric pressure go down, and you feel that you're not breathing well, and it can be called altitude sickness. It can go to edema. This is good enough to know. Now, what's the effect of pneumonia, TB, atelectasis, and acute respiratory distress syndrome? Pneumonia is infection of the lung. If you have infection of the lung, there will be some fluid in the lung. And because of that fluid, the oxygen and carbon dioxide crossing the wall is going to travel in a bigger thickness, and that will make the gas exchange decrease. So that those people having pneumonia, sometimes in the hospital, they can give them oxygen. They can give them the oxygen mask and they take some oxygen. They might, depending on the degree. Let me just go back to this real quick. Look at this membrane right here, which consists of 3 components. Imagine that here oxygen and carbon dioxide are freely crossing and everything is good. But if you have infection, you start to accumulate fluid right here. Look at this, like you're putting fluid here. So now if oxygen is trying to cross, it needs to cross the fluid and then cross the membrane itself. Now the thickness is getting bigger and the distance that the oxygen crossing is getting more. So that will lead to less oxygen crossing, and those people will have hypoxia or hypoxemia. And that's why they breathe faster to compensate. Sometimes if you go to the hospital, they can give you oxygen. They will say, okay, we need to increase the concentration of oxygen because it's not crossing that good because of the wall. And they give you other things, but not our issue. They treat the condition itself, but the point I'm trying to make is pneumonia fluid make the wall thicker, less exchange hypoxia. Good enough to know. TB, on the other hand, is one of the infectious disease. And if that happens, it's going to affect the lung, destroying some lung tissue and also making the membrane thicker, which lead to decrease the surface area. Same way. Atelectasis is something that I really want you to know. Besides the effect of those two, I just want you to know that the wall is getting thicker because of the fluids, because of the fluid in pneumonia, and because of the inflammation and infection and the TB. So the wall is getting thicker, oxygen cannot cross. Good enough to know. But for the atelectasis, I want you to actually know. Atelectasis is another name for lung collapse. When the lung, instead of staying like this, opened all the time, that's supposed to be open all the time, something can happen and lead to that lung collapse. One of those is if you accidentally aspirated something, like you're eating something or something like that, and something that's tiny entered your lung. If it goes all the way down and you go to the extent of blocking the entrance to the alveoli that are affected are going to collapse. Okay, this is called obstruction collapse. This is not the only thing. If you put anything, air, blood, fluids, anything in between the two layers of the pleura, the lung is going to collapse. But what you have to remember, atelectasis is lung collapse. Atelectasis is lung collapse. Acute respiratory distress syndrome, I just want you to differentiate between that and between respiratory distress syndrome of infant or newborn. So you will see this word instead of seeing acute. Acute is completely different, okay? Acute respiratory distress syndrome, it happened for several reasons in which the airways somehow become narrower, the blood vessels become narrower. So those people will be stressed, but not because of the surface tension. It's not because of the surfactant. So this is extremely important to remember. Respiratory distress syndrome of infant or newborn. They don't have enough surfactant. They have distress because of partial lung collapse. This is completely different. There is no issue with the surfactant. The issue is the airways becoming narrower and the blood vessels becoming narrower for some reason. Whatever the reason is, hypertension, smoking, whatever it is, not our issue. But understand that the distress is happening for a different reason. It's not because of the surfactant and surface tension. It is because of narrowing. The gas transports. Now, oxygen goes in and go to the pulmonary side, to the venous side and go back to the heart. So as it is traveling, and at the same time, the carbon dioxide is also traveling, how exactly is oxygen and carbon dioxide is transported in the blood? Like which component of the blood is going to carry that oxygen and carbon dioxide? For oxygen, it is mainly bound to hemoglobin. This is the vast majority, 98 to 99. Most of it is adherent to hemoglobin. It is attached to hemoglobin. Hemoglobin, of course, is inside the red blood cells. So it is attached to hemoglobin, 99%, 98 to 99%. And a little bit dissolved in the plasma of the blood. Okay, this is one. The other thing that I want you to know is when oxygen attached to hemoglobin, we call it oxyhemoglobin. I think it makes sense. Hemoglobin, you add oxygen, oxyhemoglobin. Hemoglobin with oxygen, oxyhemoglobin. If you take off oxygen or if the hemoglobin is releasing that oxygen, we call that hemoglobin oxyhemoglobin. So two terms that you need to learn, oxy and deoxyhemoglobin. You add oxygen, you call it oxyhemoglobin. You remove or release oxygen, you call it D. Remember, D means without. Deoxyhemoglobin. Those are two terms that I want you to know here. Regarding, beside the fact that 99% or 98 to 99% is transported, attached to the hemoglobin, actually to the iron part of the hemoglobin to be more specific, and just a little bit, 1 to 2% dissolved in the plasma. We will go to the carbon dioxide as well, but what are the, and this part is also important. I told you that oxygen attached to hemoglobin. And this is how the hemoglobin carry the oxygen. And when you go all the way to the cells, now you need to let go. Now you need to release oxygen in order to go to the cells and they can use it. How fast are you going to give up that oxygen? How fast are you going to release and become deoxy? Okay, so when you add oxygen to the hemoglobin, oxyhemoglobin. You go all the way to the cells, release it. Now you're releasing oxygen. You become without the oxygen. We call it deoxy. Now, how fast do you give up oxygen? Do you give it like really easy or a little bit like average, or you hold on to your oxygen? What determines how fast you release your oxygen? Let me say it this way. If you have like a supermarket or something and you're selling water, let's say, if I ask you like how much water do you sell per day? Like, do you give it to the customer? Of course, you can give me a good answer. You will say, well, it depends on the needs. If a lot of people are coming and they need a lot of water, I'm going to give them a lot of water. If less people, it's less water. So the amount that I'm selling and giving to the people depend on the demand. Same thing here. When the demand of the body increase, somehow they are going to release oxygen faster and easier. Examples. If the oxygen saturation in the blood goes down, you need to compensate for that because obviously the need is more. That's why your cells are using a lot of oxygen. Oxygen is going down, so the need is more. I'm going to release it easier and faster. Or if the carbon dioxide is increasing in the blood, I'm also going to compensate because carbon dioxide increased. It means that the cells are working and releasing a lot of carbon dioxide. I need to give them oxygen to use. So increase needs, same thing. Increase acidity, which is low pH. Do not confuse this. When I say increase acidity, it's low pH. Increase acidity or increase hydrogen, low pH. It's the opposite. Don't forget this. So increase acidity, why? Because increased acidity is a reflection of increased carbon dioxide. Increased carbon dioxide is reflection of increased demand. The cells are working hard, they're getting more oxygen and getting rid of carbon dioxide. Carbon dioxide increase in the blood. If that's the case, you should give more oxygen because of the increased demand. Increased temperature is another thing. When there is increased temperature, meaning there is increased heat, when your body work more, it's going to release or going to produce more heat. This means that the demand is increasing. You need to give up more oxygen. So I hope that's making sense because it's important. What are the factors affecting the release of oxygen from hemoglobin? Meaning oxy will become deoxy. Oxyhemoglobin become deoxyhemoglobin. The bottom line is increased demand. If you have increased demand, oxygen in the blood goes down, carbon dioxide goes up, acidity goes up, heat or temperature goes up. If that's the case, it's easier. And reverse that exactly without going through the details, just reverse. And this will mean that there is no need, exactly like you are in a supermarket and you're keeping your water bottles because you don't have a lot of demands, not a lot of customers. Why you want to give it? Give it to who? if there is no much demand. So you keep it for yourself until you need it later. So if the opposite happened, exactly the opposite, which is decreased demand, you're going to release oxygen slower and less oxygen will be released. Decrease the rate of release. Did that make sense? Is that understandable? Or you guys have any questions so far?
No questions.
Okay, great. So, um, the next point is oxygen saturation. Depending on what I just explained, which is how fast the hemoglobin is going to release oxygen. They make that curve, and I don't want you to know a lot of details. It's too much to know. Just know that they make a curve, and we call that hemoglobin saturation curve. And this curve will tell us like what's the relationship between the oxygen and the hemoglobin saturation, like which reflect how much oxygen you give up. Just know that this hemoglobin saturation curve, that curve change according to the demand, according to you give up more or less. Okay, one word only that I'm going to say here, and this is more than enough. This curve is going to shift to the right, meaning you give up faster, or shift to the left, you give us less or slower. That's it. More than that is too much. So this is for the oxygen transport. I already mentioned it, which is 98 to 99 hemoglobin inside the red blood cells, and the rest is dissolved. And we talked about the oxygen saturation and the release. And this is the oxygen saturation curve. Again, this is a lot of details. I give you the bottom line, okay? This is what you have to know. This curve, look at this. The one in the middle, this is normal. It can shift to the right, it can shift to the left. This is regarding carbon dioxide. Regarding pH, it can shift to the right, it can shift to the left. This is regarding temperature. It can shift to the right, it can shift to the left. What do you have to know? Instead of going through all these details, this is the core that you have to know. Does it shift to the left or shift to the right? Look at this. This is normal in the middle. This, shift to the right. This, shift to the left. Shift to the right, you give up faster. You release faster. Shift to the left, you release slower. And you know the cause, which is increased demand, decreased demand, that's more than enough. When there is increased demand, you release oxygen faster, oxygen saturation move to the right. If there is decreased demand, slowly release oxygen, the oxygen curve, saturation curve, move to the left. If you understand what I'm talking about, this is more than enough. Trust me. Just get what I'm talking about now. You don't have to go through all these details. Now the carbon dioxide, how the carbon dioxide is transported in the blood. Compared to oxygen, you have two ways only. The main 98, 99% is hemoglobin, attached to hemoglobin, and only 1 to 2% is dissolved. The situation here is different. You have three ways, not only two. Number one, it's dissolved in the plasma. And this is not 1%, it's a good percentage. Or let me say it just to make it like the other one. Number one is attached to hemoglobin, just like oxygen. Number two, dissolved to the plasma, just like oxygen. But here you have number three, which is the majority. So comparing oxygen to carbon dioxide, oxygen, 99% hemoglobin, 98 to 99, 1% dissolved. How about carbon dioxide? Attached to hemoglobin, dissolved in the plasma. So 1, 2, 1, 2. But 1 and 2 in the carbon dioxide is not the main way. The main way is number three. And number three is bicarb, which is what we talked about several times. Carbon dioxide react with water to make carbonic acid. And if you still remember, does anybody remember what was the enzyme that I told you that you need to remember that's catalyzing this reaction? Does anybody remember? There is an enzyme that helped this reaction. What is it? Start with C.
Carbonic anhydrase.
Excellent. Excellent. Yeah, carbonic anhydrase. This is the enzyme that catalyzes this reaction. And this, look at this here, carbon dioxide plus water is making carbonic acid. And this is the one that I was explaining before, carbonic anhydrase. On the other hand, it can split into bicarb and hydrogen. And this bicarb is the major part of carbon dioxide transport in the blood. So regarding carbon dioxide, you have three ways. And number three is the major one. The other two, the other thing that I want you to know, remember when I mentioned two names, oxyhemoglobin and deoxyhemoglobin? Here, instead of saying oxyhemoglobin, you say carbaminohemoglobin. Carbaminohemoglobin, meaning carbon dioxide is attached to hemoglobin. I always hear this question from the students. They say, why don't you call it carbihemoglobin, like oxyhemoglobin and carbihemoglobin? Oxyhemoglobin, oxygen attached to the hemoglobin, and carbihemoglobin, carbon dioxide. Why did you like make it more complicated? They give it that name. Of course, it's not me, because the carbon dioxide is attached to the amino group of the hemoglobin. They make it a little bit complicated, but that's okay. We have to take it as it is. Carbaminohemoglobin. Carbaminohemoglobin is carbon dioxide attached to hemoglobin. Okay? Carbaminohemoglobin. So these are the three ways: attached to hemoglobin, carbaminohemoglobin, dissolved in the plasma, and the major part is bicarb, which is the reaction of carbon dioxide with water making carbonic acid, and carbonic acid splits to make hydrogen and bicarb. This bicarb is the main transport, the major transport. In order to transport this bicarb into and out of the cells, there is something called chloride shift. You're using the chloride to exchange with bicarb to help the transport, which is not the most important thing. I already mentioned the most important, which is how exactly is carbon dioxide carried or transported in the blood. So here it is again, just to summarize it. Oxygen is two ways, carbon dioxide is three ways. Oxygen attached to hemoglobin or dissolved in the plasma. Carbon dioxide also attached to hemoglobin or dissolved in the plasma, but 70% is bicarb. And we know the reaction, and you just mentioned the enzyme that is catalyzing this reaction, which is carbonic anhydrase. By the way, I'm not saying anything that's not important. Okay, if it is not, I don't want to add to your plate. I know that the subject is not easy. That's enough for you. So, but when I say something, I know it is related. Lifespan changes as usual when we grow up and become older because of the accumulation of wear and tear. You're using your body tissues, cells, and organs, the environmental factors, the pollution, and everything. You name it, everything is going to deteriorate. Your ability to clean the air deteriorate. The cilia become weaker. If you remember the cilia that become weaker with smoking, it become weaker with age as well. But if you're smoking, it accelerates. So the damage accelerates, and it become weaker in the age of whatever, depending on how long are you smoking. But with age, the cilia become weak, less effective. The mucus is supposed to be thin in order to take as much as possible of the dust. It become thicker with age. The cough reflex and the sneezing reflex slow down. The macrophage ability decrease. You get more infections. The ability to breathe itself decrease. There are joints in your chest. There is a joint between like your ribs and your sternum, the clavicle. All these joints are going to become less mobile with the use, we call it the wear and tear effect. It become a little bit more inflamed. It become more uh, hard to move. The connective tissue become harder. The bronchioles start to lose its wall. It start to close a little bit with age. The alveolar wall become thinner, um, thinner and less effective. It's not thinner and good. Thinner means you're losing some of these cells. So when it becomes thinner, it can rupture, and instead of having intact alveoli, they are going to come together and make a big one, which is not good, of course, because you're decreasing the surface area, and so on. So everything basically deteriorates, including your ability to breathe because of everything deteriorating, the chest wall, the bones, the muscles, the lung, and so on. Everything deteriorates, and with age, um, affecting everything else. So we're done with this part, and I'm going to stop here.